Hello, everybody. Welcome to Health or Consequences. This is the Massachusetts Health Policy Podcast, sponsored by Commonwealth Beacon and Mass Inc. My name's John McDonough. I'm with the Harvard Chan School of Public Health in Boston. My co-host is Dr. Paul Hattis from the Lown Institute, and we appreciate your coming to join us today. We are very pleased to welcome as our guest Lauren Peters. Lauren is the Executive Director for the Center for Health Information and Analysis in Massachusetts government, otherwise known as MassCHIA. Some of our regular listeners may recall that we had her predecessor on our program, Ray Campbell. He has now left CHIA, and Lauren has been in charge. So we're pleased to welcome you, Lauren. Thanks for joining us today.
Great. Thank you so much for having me.
So just to start, because many of our listeners, I assume, are not deeply familiar with MassCHIA and what you do, can you tell our listeners what CHIA is, what it does, and why it's important and why it matters?
So CHIA is an independent state agency. It was established as part of the 2012 healthcare cost containment legislation and really serves as the primary healthcare data and analytics hub for the state. At a high level, CHIA is charged with objectively measuring and reporting on the performance of the healthcare system here on things like cost, quality, and utilization. I think to your question about why it matters, I'd offer a couple thoughts. I think transparency really drives accountability. One of our core roles is to report healthcare spending trends against the state's healthcare cost growth benchmark. And our ability to measure and report on individual payers and providers' annual cost growth holds those entities accountable and keeps them accountable to policymakers, regulators, and the broader public at large. CHIA's work also provides a source of truth that supports data-driven policymaking and informs targeted policy interventions and investments, turning hypotheses and guesswork to facts. And finally, it allows for systematic evaluation. It allows us to measure whether investments and policies are making a difference, assess what interventions are working, and where there are still gaps.
And it is known, Lauren, that Massachusetts is not the only state that has an entity like this. And it also is recognized that MassCHIA is probably the most in-depth and advanced such organization around the country. How have you, in your role, interacted or created awareness about all of your counterparts in other states?
Yeah, I would say, just to echo your comments, CHIA has been at this for a while now. A lot of our infrastructure actually even predates the 2012 cost containment legislation. CHIA has had sort of prior iterations and predecessor agencies. So a lot of our data infrastructure is the most advanced. In talking with counterparts in other states, CHIA is often sort of the envy in terms of our all-payer claims database, our case mix data, and some of the more advanced initiatives and efforts that we're doing with that data. So it's always great to connect with my counterparts in other states to learn best practices. I think we're always trying to evolve and improve our various data and analytic strategies. But I will say that CHIA does have a leg up, just given the amount of time that we've been at this.
So let's dive into an area of some controversy. Through most of this year, heavy attention has been paid to the Steward healthcare system and its bankruptcy. It's now in federal bankruptcy proceedings. And CHIA has actually been part of this story because for about 6 or 7 or so years, CHIA has been attempting to get financial data from Steward, which has been unwilling to present it. Can you tell us the status of that controversy right now and how else Steward has been interconnected with CHIA in the midst of this controversy?
Yes, yep. So as you noted, and just to sort of recap, Steward had failed to submit the requisite financial filings back in 2016. And as a result, CHIA fined Steward for failure to comply. In 2017, Steward sued CHIA, primarily arguing that CHIA didn't have the statutory authority to collect their audited financial statements. Just last year, the Superior Court ruled that CHIA did in fact have authority to receive Steward's financial information. Steward subsequently appealed the case, where it now remains on review. So we're continuing to work with the Attorney General's office, who's representing CHIA in this case, and expect the appeals court to hear the case later this year.
So can you tell us how else CHIA has been engaged or involved in the Steward controversy beyond the financial reporting issue that's now in the court system?
Sure. So CHIA has been actively supporting our sister agencies across state government through the provision of data and an analysis related to hospital utilization and financial performance, as folks try to plan and continue to sort of stay prepared for whatever situation may unfold.
Paul.
Lauren, we add my words of welcome and jump really to an issue which is sort of at the heart of way many of us on the policy side think about CHIA, which is it's the agency that puts the numbers together on an annual basis to tell us how are we doing in terms of overall growth of healthcare spending in the state, and as you guys call it, the total healthcare expenditure number, and compare it to what has been established as the state's benchmark. Now, you recently reported for 2022, the latest data available, that the THCE grew at 5.8%, but we have 23 completed. We're in the midst of 24 now, and then moving into 25. Any words or thoughts you have about looking at the overall trends and where we seem to be going with overall state healthcare spending that you can share with our audience today?
Sure. So as you noted, our most recent data shows a 5.8% growth rate, which represents the highest one-year growth trend since measurement began in 2012, with the exception of 2021, which I really view as anomalous due to pronounced rebounding of utilization due to the pandemic. And so while some of the spending trends can be attributed to and should be viewed in the context of the extraordinary circumstances of the pandemic, I'm not optimistic that the spending trends will improve absent meaningful reforms, given that as a system, we've exceeded the benchmark in the last 4 of 5 years. And many of the trends and cost drivers, including pharmacy, hospital outpatient, have been consistent contributors to overall cost growth, even prior to the pandemic.
So, Lauren, let me jump to, you mentioned that the overall numbers are, things to potentially worry about given some of those trends. But as you mentioned, your agency is the truth teller, and you also dive in to aspects of individual provider, insurer organization performance. And looking at your website and dashboard, you could see, for example, that over recent years, some of our largest healthcare systems and wealthiest historically, like MGB or Children's or Dana-Farber, their net assets have grown substantially from the 2019 to 2023 era. Others either not growing at all or even declining. Any thoughts you have or observations you want to make around those kinds of data coming about individual provider systems?
Sure. So as we know, heading into the pandemic, hospital systems were starting in different financial positions, and those with significant assets were in a better place to weather the challenges of COVID. But to your question, and just to put some numbers on the issues, in the aggregate, hospitals reported a $21.3 billion increase in net assets from 2019 to 2023. And while most systems, because 18 of 23, saw an increase in their net assets during this time, as you pointed out, systems experience a varying degree of financial impact. And I think the pandemic had a compounding effect. Many of our safety net and less resourced hospitals were often those serving communities that were disproportionately affected by COVID. And it was the same hospitals that had to rely more on temporary labor, factors that had a compounding impact on their bottom line. But it is worth noting that the state was really intentional about targeting relief funding to mitigate the impact on these hospitals. And so that is reflected in their operating margins when we look at 22 and 2023 data.
So to jump into another area of policy focus and concern both in our state and really across the country is the whole challenge of the availability of primary care. And wondering, Lauren, does CHIA data support or put any doubts on the widely held belief of the crisis that we think we're experiencing in primary care, and how do we shape up on that issue compared to other states or the rest of the nation?
Yes, I would say CHIA's data absolutely supports that notion. Even prior to COVID, we were sounding alarm bells around primary care access issues, which were only exacerbated by the pandemic. So over the last several years, recognizing the importance of the issue, CHIA has been tracking and reporting on the performance of the primary care system through our dedicated primary care dashboard. The data on the dashboard shows real concerning trends. We have primary care physicians leaving Massachusetts at a faster clip. Just in the most recent data, we saw 5.6% of physicians leaving primary care in Massachusetts, which is an increase from 2019. Our 2023 resident survey data shows increasing access challenges, with over 40% of residents reporting difficulty obtaining healthcare in the past 12 months, which is up from 33% in 2021. But on some levels, we shouldn't be surprised by these trends when we look at how much as a system we're spending on primary care. Of the nearly $70 billion we spend on healthcare each year in Massachusetts, we're only spending 6.4% of that on primary care. With respect to how we stack up to the rest of the country, I would look to some of the work that Milbank has done in this space. They published a national scorecard on primary care, which shows Massachusetts doing better in some areas and worse in others. For example, Massachusetts is on par with the national average when it comes to primary care spending as a percent of total healthcare spending, but Massachusetts has a higher rate of physicians leaving primary care than the national average. So I think that while we still have a lot of work to do here in Massachusetts, the trends that we're seeing are not so dissimilar from what we're seeing elsewhere in the country.
Just as a follow-up on Paul's question about primary care, do we see any explanation for why there are such a high level of physicians, primary care physicians, who are leaving Massachusetts?
The short answer to your question is that there are a number of factors driving primary care docs out of Massachusetts, but also we see sort of a stymied effect on fewer primary care docs entering the primary care field as they're graduating from medical school. And some of the contributing factors are around burnout. We know some of the additional administrative burdens the primary care docs are being asked to take on is certainly contributing to that burnout. But when we think about medical graduates entering and selecting the field that they're going to go in, with primary care sort of on average receiving lower reimbursement with on average lower salaries, it really isn't a surprise that fewer medical graduates are entering the primary care space, and that we have more and more primary care physicians that are leaving Massachusetts.
Those are national trends that are everywhere. Does the data show anything about what explains a larger than average exodus from Massachusetts? Is there something going on in Massachusetts that is exacerbating this? Because physician burnout is all over the country, and electronic health record burnout and all of that.
I don't know that we see any Massachusetts specific data that would explain those trends. As I noted, we saw a reversal of this trend. So back in 2019, Massachusetts, sort of the rate of primary care docs leaving the state was actually less than the US average. So it was really from 2019 to our most recent data, and I believe was from 2021, that shows this trend reversal. And we see more primary care docs leaving Massachusetts higher than the US average. And part of that could be explained by the disproportionate burden that I think Massachusetts felt as compared to other parts of the country due to the pandemic, but it's probably still too early to say what's driving or what's underlying these trends. Be interesting to see in another year or two from now whether this trend is an anomaly or whether it's sustained, and Massachusetts really is having a more sort of pronounced challenge with an exodus of primary care docs.
So going beyond the primary care physician problem and pressure, I know CHIA is also looking at the entire state healthcare workforce in terms of where we stand, where there are the most difficult and acute shortages and maybe some areas of opportunity to be able to address the shortages. What has CHIA been learning, and what have you learned in your 18 months at CHIA about the overall state healthcare workforce?
Workforce was an issue top of mind when I joined CHIA, and one of our top priorities over the last year has been to develop a fact base that really quantifies the healthcare workforce challenges, looking at vacancy rates, turnover rates, and the racial composition of staff across a number of settings. And we released findings from our survey in a dashboard just last month. If you haven't had an opportunity to see it, I would encourage folks to check it out on CHIA's webpage. And I would say that the findings are not all that surprising. We see the highest vacancy and turnover rates among lower wage direct care workers working in nursing facilities and in the home care space. And these are the same roles where we see the greatest racial and ethnic diversity. So again, while neither positive nor necessarily surprising, this effort provides us with baseline data, and we intend to field the survey on a every other year basis, which will enable us to measure progress and the impact of investments and other efforts in this space.
As a follow-up, in this COVID era, the hospitals in particular have talked about the high expenses of travel nurses and the like. Does CHIA have any data about that issue, and are things getting better in that regard that you could share with our audience?
Yes, this was one area that we started a new data collection stream on because of the impact that temporary contract labor was having on hospitals, but other healthcare settings across the system. And one positive bright spot is that the hospitals in the aggregate are relying less and less on temporary contract staff. I think we saw an aggregate decrease in reliance on temporary staffing of about 13% between 2022 and 2023.
I guess I'll ask another follow-up here. You mentioned the demographic data you have about workers, and Massachusetts has seen a number of immigrants come to the state over recent years. Any evidence that they're taking jobs in our healthcare sector in significant numbers, either acute care or non-acute care, long-term care, and the like, and any data you can share with us there?
Yeah, it's an interesting and timely question. I will say that the immigration status was not something that we asked about or included in our 2023 workforce survey, but we've already started developing the 2025 survey, and this is definitely a dimension that we can consider including for future iterations.
In recent CHIA reports and voices from the small business community, particularly John Hurst from the Retailers Association, we've heard that there's a significant drop in the numbers and rates of smaller employers who are providing health insurance to their workers. I'm wondering if you have seen or noticed that data yourself, and is Massachusetts facing a significant transition in terms of losing a substantial amount of the employers who provide health insurance to their workers?
Yeah, our data shows those very trends. Over the last 4 years, enrollment in employer-sponsored insurance has declined by over 5%, which equates to nearly 200,000 members. And while some of the declines in ESI could be attributed to federal requirements for continuous coverage on mass health during the pandemic, it's likely not a significant driver, as we were seeing these trends even before the pandemic. So I'm eagerly awaiting results from our next enrollment trends report that will be released sometime in the September timeframe, as it includes data through March 2024 and will give us a sense of coverage transitions at a high level following the redetermination period.
It'd be interesting to know the people who aren't getting employer-based coverage. Are they moving to Mass Health? Are they moving to the marketplace for individual coverage, the Mass Connector? Or are they going uninsured? Would be important to know. Do you have any data at this point, or is this still too premature?
Yeah, I mean, over the last couple of years, the data shows sort of increases in Mass Health enrollment, as well as connector care and individual coverage through the connector. But I think that because of the very dynamic landscape over the course of the pandemic, the last 4 years, I think the part of the reason that I'm so excited for this latest enrollment trends report is it'll be sort of the first time that we see where some of the dust has settled, and to understand which of the pre-pandemic trends sustained versus some of the new enrollment trends that we saw over the last couple of years, are those representative of future ongoing state?
But finally, Lauren, Massachusetts state government and really many healthcare system stakeholders are publicly committing to improving healthcare equity across the state. Any important data that you guys as an agency put out that intersect with the equity issue and how we're doing that's worth sharing with our folks today?
Yeah, thank you for that question. I would say CHIA as an agency is certainly no exception in terms of our commitment to health equity, and have been actively supporting both ongoing external efforts in the space and at the same time continue to expand and enhance our data and analytic capacity related to health equity. In terms of the greatest needs, I think the disparities that we've seen in some of our utilization and access data have struck me the most. When looking at average length of stay in our hospital inpatient data, Black patients consistently have longer hospital stays compared to their white counterparts. Hispanic residents and Black residents were almost twice as likely to go to the ED for non-emergent conditions than their white counterparts. And I think that the higher reliance and utilization in acute settings should come at no surprise in some respects when we see the disparities in access further upstream. For example, Hispanic and Black residents reported lower rates of preventative care visits than white residents. And some of this problem is supported by our resident survey data that shows Hispanic and Black residents reporting lower rates of health insurance coverage and greater challenges affording care than their white counterparts. So when we think about timely, right care, right place, our data shows our system is failing certain populations more than others, and does make a compelling case for targeted interventions and investments to increase access to preventative upstream services for some of these populations.
Lauren, thank you for your answer for that, but really thank you for spending the time with John and I today. We really appreciate it, and we know our audience will gain a lot from hearing about the agency's work. Thanks again for joining us.
Well, I want to thank you for having me and the opportunity to chat with you today.